Hello, everyone. Did you hear me?
Yes, Professor Kim,
Cha Jung
nice to
Ho.
meet you.
How have you been?
Yeah, I'm fine.
Good to
Okay,
see you
we
even in the online. Yes, it's very nice to Dr. Fuh, Professor Fuh.
Hi,
mhm,
nice to
Yes,
meet you.
nice to meet you. Yes, it's
Yeah,
really been a long time. Yes,
yeah,
yeah. Mhm.
yeah.
we are about to start. Professor Fu,
Okay.
please.
Okay. Professor Yun Kim is our good friend. Yeah. He's now at Department of Neurology, Seoul National University College of Medicine, and he's also the director of Neurocognitive Behavior Clinic, Seoul National University Bundang Hospital, and he's a leader multidisciplinary Alzheimer's disease or marker study. His clinical activities focus on patients with dementia caused by various disorders, including mild cognitive impairment and transient global amnesia (TGA). His working group has well-established patient database of dementia, especially early onset Alzheimer's disease, also human proteinopathy, transient global amnesia. He had participated as principal investigator in many phase 2 and 3 international and national clinical trials for new compound for treatment AD and VAD for many pharmaceutical companies. Let's welcome Professor Kim.
Thank you for your nice introduction, Professor Fuh and Cha Jung Ho. Yes, you are my old friends. And I hope to see you again in the future, the face-to-face, to discuss many advances in the field of the Alzheimer's disease and related disorders. And again, thank you for inviting me to this excellent lecture series. Okay, the blood-based biomarker is the hottest topic in the field of Alzheimer's disease. So today, I will briefly review this topic and talk about our present work and the future plan on this field, including AD control. Here are my disclosures.
Um,
Okay, uh, is there any problem on the line?
no,
We
we don't
cannot
see a
see
slide.
your PowerPoint.
Slide. Okay, okay. I'm so sorry. I have to share my slide.
Yeah.
Okay.
Mm-hmm.
Okay, can you see my slide?
Yes, it's
Okay,
nice.
good. Okay, I will move to the next slide. So this is my disclosures. Okay, let's start with this slide. This is a schematic table of the molecular underpinning of neurodegenerative disease and their main clinical diseases. This figure lists genes with full penetrance that are considered the causative and risk genes that influence the molecular process, culminating in the misfolding and aggregation of 6 fundamental proteins, including the prion protein, beta amyloid, and the tau, and TDP-43, and the FOS, and alpha-synuclein. And also, the 4 major pathologic disease categories are recognized: the prion disease, prionopathy, and Alzheimer's disease, and the frontotemporal lobar degeneration, and the Lewy body diseases. The pathologies can involve multiple molecules. For example, the Alzheimer's disease is a dual proteinopathy with a beta amyloid and tau, and the majority of frontotemporal lobar degeneration cases are associated with the 3 different proteinopathies, tau and TDP-43 and FUS. And this slide shows the function and the category of the biomarker, and there are several roles of biomarker in Alzheimer's disease. And we need a reliable biomarker which can help us to make an accurate diagnosis of Alzheimer's disease based on the particular pathomechanism. namely the cerebral beta amyloidosis. And to promote the clinical trial, we need the biomarkers, which can detect patients at the preclinical or very early symptomatic stage of Alzheimer's disease. But the most important role of a biomarker in AD research is that of monitoring. With this monitoring biomarker, we can screen easily compounds or the treatment methods which can prevent or efficiently treat Alzheimer's disease. So this monitoring biomarker is very essential for disease-modifying treatment research. In comparison, the HbA1c, the glycated hemoglobin, played all these roles in type 2 diabetes. There are two representative neurodegenerative diseases, the Alzheimer's disease and Parkinson's disease. Each of these has their own specific abnormal proteinopathy, amyloidopathy and tauopathy for Alzheimer's disease, and alpha-synucleinopathy for Parkinson's disease. In the past, we didn't know the exact pathomechanism of neurodegenerative disease, but now we know well the accumulation of abnormal protein in our brain is the main mechanism of the neurodegenerative disease. So the term neurodegenerative proteinopathy or proteopathy is being used to highlight this point. There are several reasons why blood-based biomarker is so important for Alzheimer's disease in clinical practice. These biomarkers are very important to diagnose Alzheimer's disease accurately, especially at the very early stage, including the preclinical stages. Also, this biomarker can optimize treatment strategy and provide appropriate management options. If these blood-based biomarkers are reliable, this can replace many kinds of expensive tests for the diagnosis of Alzheimer's disease. In detail, the clinical diagnosis of Alzheimer's disease is not so easy, so about 30% of patients with a clinical diagnosis of Alzheimer's disease are misdiagnosed. The inaccuracy of clinical diagnosis is even worse in frontotemporal dementia or the dementia with Lewy bodies. So these two disorders have the nickname of the most common rare disorder. And also the mild cognitive impairment state is an etiologically very heterogeneous. So up to 50% of MCI patients have incipient Alzheimer's disease pathology. And the underlying etiology is very difficult to be determined without biomarkers. Recent development of ultra very sensitive technique made it possible to measure very low concentration of protein in plasma, and the sensitivity and specificity are quite good. However, they are still insufficient to be used as a single diagnostic biomarker due to the large overlap of concentration value between normal control and the patients of Alzheimer's disease. As the development of a measurement technique and by the knowledge about the amyloidopathy of Alzheimer's disease will improve the efficacy of plasma beta amyloid as a blood-based biomarker of Alzheimer's disease. Until now, the mass spectrometry and the CMOA technique is the highly available techniques in measuring the beta amyloid in plasma, but as you know, the efficacy is very limited. And also recently, there has been advanced in plasma tau biomarker research. Plasma p-tau 181 and p-tau 217 can differentiate patients with Alzheimer's disease pathology from those without and those with non-AD tau pathology. Plasma p-tau 217 actually performed equivalent to CSF-AD biomarkers and tau PET imaging. with an accuracy about 90%. Plasma p-tau exhibits clearly increase over time in pre-symptomatic and prodromal Alzheimer's disease and could potentially be used to detect effect of disease-modifying treatment, and now is being used in many clinical trials now. Plasma p-tau 181 and p-tau 217 levels are associated with both A-beta plaque in early stage and tau tangles in later stages. According to autosomal dominant Alzheimer's disease study, this tau blood-based biomarker increased 15 to 20 years before symptom onset. In sporadic Alzheimer's disease, the p-tau 181 and p-tau 217 increase during the pre-symptomatic phase when the cortical A-beta fibril emerge and before positive tau PET in neocortex. Another point that we have to consider is this. The prevalence of all comorbidities increase with age except for Lewy body disease. Elderly AD patients often have several different brain pathologies simultaneously with widespread beta amyloid pathology. In the future, if we have a protein-specific treatment option, for example, the beta amyloid lowering treatment or the alpha-synuclein lowering treatment or tau targeting treatment, the proteinopathy profiling of patients may be more important than the clinical phenotype in Alzheimer's disease or other neurodegenerative disease treatment. There are several big advantages of a plasma biomarker of Alzheimer's disease. For example, the easy accessibility and good safety and low cost. Therefore, serial tests are possible in clinical practice. Even we can use these blood-based biomarkers. But measuring the concentration of a specific protein, as like the beta amyloid in plasma, is quite difficult for several reasons. This is a list of a limitation to the direct measurement of a plasma beta amyloid concentration in plasma, which would hinder the development of amyloid targeting blood-based biomarkers. To mention few, very low concentration, relatively low concentration of beta amyloid compared to CSF, and the presence of many interfering blood proteins, especially the A-beta binding protein or autoantibodies. And the pattern shift from the monomer to dimer, tetramer, dodecamer, or protofibril and fibril, this kind of the pattern change of beta amyloid is a big limitation of the development of a blood-based biomarker. If so, what are the next steps for blood-based biomarkers of neurodegenerative disease in practice, in clinical practice? Reliable blood-based biomarker as a high-precision in vitro diagnosis technique is the most important goal in the field. And also, with this kind of basic research, we need the standard operating procedures for collecting and handling or the pre-analysis of the blood samples and the optimized diagnostic algorithm combining different biomarkers or other factors, apply for E protein or the age or gender like that. And we should use these biomarkers appropriately to avoid misinterpretation and misuse. This is a comparison table of AD biomarkers. In Korea, there is no commercial service of a CSF biomarker study. We are doing this kind of a CSF biomarker study only for research setting because the cost for amyloid PET in Korea is relatively cheap to study. There is no need for somewhat invasive CSF study. The cost of the amyloid PET is around the 700 to 1,000 US dollar, and around the 150 centers are available to amyloid PET study. So it's a very common study in Korea, amyloid PET. And finally, the MDS-OA beta is the only Korean FDA-approved blood-based AD biomarkers. This MDS-OA beta is being used commercially at most of the special dementia clinic or the health promotion centers in Korea. Now, let's talk about the Alzheimer's disease control. Actually, this table is a total care plan for patients with Alzheimer's disease in Korea. It was divided into 4 steps: prevention, control, and treatment, and also finally the management. We are well aware about the prevention and treatment, but a little about the control and the management. We've already had a lot of discussion at the control and the management in different directions, and I just hope that today's presentation will be an opportunity to make these more specific. This AD care plan is arranged and based on the opinions of Korean dementia experts, and many dementia clinics in Korea accept this as a standard concept of caring patients with Alzheimer's disease already, but we are trying to reflect this AD care plan concept in National Dementia Care Policy. This is a diagram of clinical progression of Alzheimer's disease, and this yellow line means a slow decline of cognitive function, and this is the point of the beginning of the cognitive impairment. And then we can diagnose a patient with Alzheimer's disease dementia and Alzheimer's disease MCI according to the severity of cognitive impairment if this diagram represents the Alzheimer's disease course. As the pathological state of Alzheimer's disease starts decades before the clinical symptom, there is a relatively long preclinical stage or the presymptomatic stage of Alzheimer's disease. According to the diagnostic criteria of Alzheimer's disease from NIA-AA and the International Working Group, we can diagnose a person as Alzheimer's disease at any stage of this spectrum if they have any evidence of cerebral amyloidopathy. And Alzheimer's disease became a particular disorder based on a specific molecular pathomechanism, not as a clinical syndrome. We have 2 current options as a way to deal with Alzheimer's disease patients: the prevention and treatment. The dictionary definition of prevention is the action of stopping something from happening or arising. And we only have 2 pharmacological treatment options to date: cognitive enhancement with cholinesterase inhibitors or memantine, and the pharmacological control of abnormal behavior and the psychiatric symptoms. There are many kinds of guidelines for AD prevention, but the content are different according to origin and are easily changing because it's hard to say that there are enough evidence to support this prevention effect. In fact, it cannot be said that the prevention of Alzheimer's disease is different from the prevention of general dementia or the general cognitive decline, because it is not possible to specify Alzheimer's disease at the point of prevention. This is a simple summary of prevention and treatment of Alzheimer's disease. Some experts said that we could prevent or delay 40% of general dementia cases worldwide if we could reduce or completely eliminate these risk factors. But in fact, it is impossible to get rid of even one of them completely. And we can treat Alzheimer's disease with the clinical symptoms with this cognitive enhancer and many kinds of BPSD medications. Prevention is traditionally divided into 3 levels: primary, secondary, and tertiary preventions. Primary prevention refers to reducing the incidence of the disease by eliminating or treating specific risk factors, which may decrease or delay the development of the specific disease. In the case of Alzheimer's disease, people currently without any signs or symptoms of Alzheimer's disease could remain without AD through the primary prevention strategy. Tertiary prevention ameliorates the impact of complications and the disability of long-term disease. Thus, it allows patients to maintain an acceptable quality of life. Secondary prevention aimed to detect the disease at an early stage before any symptom has emerged, when treatment could halt or limit its progression. In Alzheimer's disease, secondary prevention is not to progress from the state of positive AD-related biomarker without any cognitive impairment to clinical state. In fact, this is very same with diabetic mellitus control, DM control in type 2 diabetes. When someone who has a high level of blood glucose or glycated hemoglobin, they need to take medication to lower the blood sugar level or HbA1c value to stop the occurrence of diabetic complication by end organ damage, as like the diabetic nephropathy or diabetic retinopathy or diabetic neuronopathy. For the treatment of Alzheimer's disease, we have two options. As I said, the one is cholinesterase inhibitors and memantine to enhance the patient's cognitive function, and the other is many kind of the pharmaceutical compounds for the control of BPSD. And also we have a very long list of candidates drug, including disease-modifying treatment of Alzheimer's disease. I sincerely hope that many of these compounds will be developed in near future and will be used effectively for the treatment of Alzheimer's disease. I am sure that will be the case, and I am also participating in the study of some very, very promising candidate drugs. So this is the first table of care option of Alzheimer's disease, prevention and treatment. Cholinesterase inhibitor and the memantine or like that. And the cholinesterase inhibitors are available for AD dementia only and often for AD MCI, although there is not enough evidence for this the MCI state. However, in the case of a severe dementia of Alzheimer's disease, a different and more careful approach is needed. This severe dementia state may be a totally different clinical situation from the mild dementia or MCI. However, very few studies are involved because the big pharmaceutical companies are not interested in this issue. Therefore, we separated this severe dementia stage of Alzheimer's disease from the mild dementia stage. Treatment of AD dementia and management of severe dementia stage of Alzheimer's disease. Since the term management is used in a broader sense, I don't know if it would be appropriate to use this limited to severe dementia conditions, but our team decided to use this term management until a better term came out. At this severe dementia stage, treatment focusing on the cognitive impairment is not so important anymore. We need another protocol or another guideline for the care of these severe dementia patients and their caregivers. Especially the stage after severe dementia of Alzheimer's disease, the stage after severe dementia stage. Patients couldn't do nothing for their basic activity. This stage is very different with just severe dementia, just being evaluated only by the the cognitive test or CDR or the MMSE like that. Even we don't have the specific term for this last stage of Alzheimer's disease. I think this special attention is required for this stage of Alzheimer's disease because in this state, cognitive enhancer is not important anymore, and attention should be required for complication or accident prevention. Also, this state lies outside the interest of pharmaceutical companies, and there are special consideration of palliative care or ethical issue or the planning for the terminal care. This is a relatively neglected stage for study. And finally, we have to support caregivers' emotion and their quality of life, caring the last stage of the Alzheimer's disease patients. We already saw this slide. If someone had a restricted brain or cognitive reserve due to the repeated trauma or the heavy drinking or lack of education or any kind of reason, the cognitive impairment appears earlier than usual if he got Alzheimer's disease. If we treat Alzheimer's disease at the very early stage, we could reduce the dependent and severe stage of dementia by expanding the independent and mild stage of cognitive impairment. Probably this is the real effect of symptomatic treatment of Alzheimer's disease. But if we can detect this pathological change at preclinical stage and can slow down the progression speed of cerebral amyloidopathy just a little, I think we can live our whole life without any kind of cognitive impairment, even though there is some amyloidopathy in our brain. It's like the height of amyloidopathy. This is the concept of AD control, and which is similar to secondary prevention. To do this AD control, the first thing we need is a reliable biomarker to detect Alzheimer's disease at preclinical stage. The first to summarize, the AD control is the concept of Alzheimer's disease care, which prevents Alzheimer's disease in preclinical stage from progressing to symptomatic state. The most important step to do this is to diagnose Alzheimer's disease before clinical symptoms appear, and the biomarkers are absolutely necessary for this. This is a criterion for ideal biomarker for Alzheimer's disease proposed by the Ronald and Nancy Reagan Research Institute, NIA, at 1998. By the definition of Alzheimer's disease, A-beta or A-beta oligomer must be the fundamental target because they are directly related to the pathogenesis of Alzheimer's disease. And by the recent consensus, the minimal sensitivity and specificity were upgraded to 85%. And the ideal biomarker for AD could detect Alzheimer's disease at the preclinical state with a high reproducibility. And finally, this ideal biomarker must be non-invasive and simple and cheap to test. When we put all these things together, the most reliable biomarker must be the blood-based and the amyloid targeting biomarker. MDS-OA-beta is the first commercially available blood-based biomarker of Alzheimer's disease, which can estimate the risk of Alzheimer's disease even at the preclinical stage of Alzheimer's disease. And the MDS, the Multimer Detection System, is the fundamental technique of this MDS-OA-beta. Multimer Detection System, MDS, is an atypical ELISA technique using the overlapping antibodies for the detecting and capturing antibody. This MDS can detect oligomeric form of target molecule exclusively in the mixture of the monomer and oligomers. In 2017, we found an interesting phenomenon when we spiked the synthetic A-beta 42 into the plasma sample from the Alzheimer's disease patients and followed by incubation, the oligomeric A-beta 42 concentration was significantly increased after slow decreasing phase. This A-beta 42 oligomerization tendency was very specific only in plasma from Alzheimer's disease patients. This tendency was not observed in plasma from healthy normal control or during A-beta 40 experiments. Interestingly enough, there was no change of total A-beta 42 or total A-beta 40 level during this incubation. When we measured the oligomeric beta amyloid concentration by MDS directly before spiking or incubation, there was no difference between two groups, the Alzheimer's disease group and normal healthy control group. But they could make a valid difference by spiking and incubation like this. We had tested this method repeatedly with many sets of plasma samples, and this was the accumulated data, including 251 AD samples and 228 age-matched control samples. Some of them were also studied with PPET or triple CSF biomarkers as well. There were good correlation between MDS-OA-beta plasma value and the PPET or the CSF triple biomarkers. In a clinical trial designed to get approval of Korean FDA, we performed a randomized assessor blind study. We selected 52 plasma samples of clinically well-characterized Alzheimer's disease patients and 52 plasma samples of normal healthy control. These samples were sent to the separate blinded laboratory after anonymization and randomization. In this study, all 52 AD plasma samples were found to be positive, and 48 of 52 plasma samples from normal control were negative, indicating 100 sensitivity and 92.31 specificity. AUC value was 0.99. Separating these 80 cases according to the clinical severity, there was a consistent tendency of decreased MDS-OA-beta values according to the severity of dementia. 29 cases of AD were also studied by the amyloid PET, and 28 cases were positive, and one case had a negative amyloid PET result. But these patients had a very typical CSF triple biomarker profile of Alzheimer's disease. This study was done by my colleague Professor Yun to see the correlation between MDS-OA-beta value and the brain structural changes. We collected 162 subjects who were studied by the structural brain MRI and an MDS-OA-beta blood test, including 92 health control, 17 SCD, 14 MCI, and 39 AD dementia. To determine the structural MRI change of the brain, that are statistically correlated with the MDS-OA-beta value, we used voxel-based morphometry with the correlation for AG and total intracranial volume covariates. Gray matter volume reduction were in the bilateral medial temporal parietal region and the precuneus regions, which are exactly same to area of specific cortical atrophy pattern of Alzheimer's disease. This finding suggests that increase of MDS-OA-beta value in the plasma is well correlated with the brain volume reduction in the pattern of Alzheimer's disease. This is a figure presenting sequential change of pathophysiological processes in Alzheimer's disease. The tendency of beta amyloid oligomerization reaches its maximum in the MCI or the early dementia state of Alzheimer's disease, whereafter it declines in the severe dementia phase. This bell-shaped curve graph is obtained from the derivatives of the sigmoid function, which present the MDS-OA-beta value as a dynamic change in Alzheimer's disease in the beta amyloid. Last year, the Halleck Jetterberg published a model of the temporal pattern of biomarkers abnormalities for Alzheimer's disease-related pathophysiological processes. In this figure, the soluble TREM2 protein, also the CSF soluble TREM2 protein also has a bell-shaped curve, which is exactly similar to MDS-OA beta. So this kind of the bell shape shows some kind of the dynamic change of the plasma, not the total concentration of the peptide. MDS-OA beta is the technique to measure oligomerization tendency of the patient plasma by MDS after the spiking of the synthetic A beta in incubation. It must be a blood-based beta amyloid-related biomarker, but focusing on the plasma characteristics, not measuring the beta amyloid or related peptide itself directly. There have been many studies to confirm the reliability of this MDS-OA beta test, and based on the result, it has begun to be used in actual clinical practice to evaluate the AD risk and to diagnose the patients of Alzheimer's disease and to monitor treatment effect. High value of MDS-OA beta does not mean the diagnosis of Alzheimer's disease, but mean that the patient is at the high risk of Alzheimer's disease. So we have just finished the second study of MDS-OA beta, recruiting about 2,000 samples, including many kinds of diseases that. From this, we now know the MDS-OA beta can be changed, increased or decreased by some drug or situation. So we are trying to find the optimal drugs which can reduce this value easily. This table shows the summary of reasoning explaining the mismatch between the clinical diagnosis and the OA beta value. Even in the patients with the typical Alzheimer's disease, this kind of at the severe stage of Alzheimer's disease, this MDS value can be detected very low, and some the chemotherapy agent or long-term medication as like the anti-TB medication or some long-term medication for the rheumatoid disease or the passive immunization or base inhibitors. These kinds of the treatment can lower the MDS value dramatically. And even in the normal person, just after the heavy drinking, this MDS-OA beta is increased a lot. And this table is a diagnostic guideline distributed to real clinical practice to the clinical doctors, and which is used to interpret the result of MDS and a neuropsychological test and brain MRI all at once. What we know about the MDS-OA beta until now are the Alzheimer's disease versus cognitive normal person differentiated power is 0.84 and 0.99. Amyloid positive prediction power was 0.74 and 0.85. And MDS-OA beta is well correlation with the brain atrophy pattern of Alzheimer's disease and with the decreased general cognitive function and with the episodic memory performance in Alzheimer's disease. And we also confirm the big potential as a pre-screening tool for amyloid PET. And there are some the contents we should study more. Okay, and there are indeed a lot of factors associated with Alzheimer's disease, and these many factors are known as the main contributor for the occurrence of Alzheimer's disease, but anyone cannot explain the more than 30% of the Alzheimer's disease case. These heterogeneous factors converged to one of four A beta-related mechanisms: the increased production or increased oligomerization or decreased degradation or decreased clearance. And the final common pathological phenomenon may be the long-standing hyperoligomeric beta amyloidosis in our body. And then this kind of the oligomeric A beta is accumulated our brain as like the end organ damage, and that is the Alzheimer's disease. We need a comprehensive biomarker matrix to find underlying responsible factors for each AD patients to prevent amyloidosis. But at the stage of the increased oligomeric beta amyloid, we have to find a way to decrease this value to slow down the progression of a cerebral amyloidopathy. These are summary figures of biomarkers related to Alzheimer's disease. Hippocampal atrophy and other Alzheimer's disease-related specific focal cerebral amyloid pattern in brain MRI are the very important structural neuroimaging biomarker of Alzheimer's disease. And amyloid PET is the molecular neuroimaging biomarker for Alzheimer's disease. And we can measure CSF A beta 40 to A beta 40 and their ratio as a CSF biomarker. And now we can measure plasma A beta 40 to N A beta 40 by the sensitivity techniques and the oligomerization tendency of plasma by MDS-OA beta method. We can't say which one is better than the others because its utility value depends on the clinical setting and situation. If we take these biomarkers all together, we can have better understanding to the real pathomechanism of beta amyloid and Alzheimer's disease. This is a simple diagram of amyloid cascade or the amyloid hypothesis. And now we know that the oligomeric beta amyloid is the most toxic species of beta amyloid in our body. And the CSF and the peripheral circulation system are closely connected to this cerebral amyloidopathy system. And there are multiple steps where we can detect changes in patients with Alzheimer's disease. Now, our team starts to investigate the relationship of these markers together, the amyloid plaque imaging, amyloid PET imaging, the plasma A beta 40 to N A beta 40, and the exosomal A beta 42 monomer or oligomeric form, and finally the oligomeric A beta and the plasma oligomerization tendency by MDS-OA beta. We call this combination as beta amyloid profiling. Detection of preclinical AD patients by AD biomarker and manage them to reduce this biomarker value, not to progress to clinical staging. I'm looking forward to the day when we can control Alzheimer's disease as soon as possible so that people can be free from fear of Alzheimer's disease dementia. Again, MDS-OA beta is the technique to measure oligomerization tendency of a plasma by MDS after spiking synthetic A beta. It's a blood test and beta amyloid targeting biomarker of Alzheimer's disease, but focusing on the plasma characteristics, not measuring beta amyloid directly. Our next goal is the beta amyloid profiling to get a better look at the patient's AD pathology. And our final goal in the field of biomarker is to develop the technique measuring multiple proteinopathy or proteopathy markers together as neurodegenerative proteinopathy profiling. I hope this concept map could give you new ideas for clinical setting or research. I'd like to do something for these amyloid positive but asymptomatic patients not to progress to symptomatic state more efficiently. I hope we can fill this red area as many good options, drug or some kind of the exercise or many kind of non-pharmacological measures as soon as possible. There are many colleagues working together in clinical and basic research setting. I'd like to thank you to all of them. Thank you for your attention.
Thank you for your talk. Any question from the audience?
Yes, I'm Dr. Hu.
Okay.
Professor Kim, congratulations for the wonderful study.
Thank you.
In Taiwan, we also have a tool to measure the amyloid and the tau in the plasma. It calls IMR, immune magnetic reduction technique.
I know well about that.
Yeah, but you know, we face a very difficult decision because more and more evidence support the p-tau 181 or 117, like use the Simoia system. So, what do you think? In the future, should we follow the like a global trend to use the Simoia system or other system, or we should keep our study on the by use this kind of a little original method?
Okay. If someone is in the situation of the clinical trials, and yes, we diagnosed someone as Alzheimer's disease by the A beta related biomarkers, as like the amyloid PET or the CSF biomarker of Alzheimer's disease. Okay, so these patients must be Alzheimer's disease, and to monitor the drug effect, we can use the p-tau. But without this kind of the treatment effect in many clinical situations, but it's not the diagnosis of Alzheimer's disease. So it's a kind of the additive the biomarker for the diagnosis of Alzheimer's disease, because according to the many experts, the biomarker should be directly related to the pathomechanism of the disease. So the primary biomarker should be amyloid targeting. Okay.
Okay, thank you. But it's like a resources allocation. You know, if we use the like MDS or A beta system, we cannot use the Simoia system in the same time. So my question is that what kind of tool will you choose in the future?
Yes, the measuring something by the Simoa or the mass spectrometry is first of all, it's a very quite expensive technique. Probably until now, the C2N provided the commercial service by the mass spectrometry, and the Simoa, we are using the contrast Simoa machine for the comparison of our technique and Simoa. If the only one sample to evaluate the one sample, it's more than the anyway, it's more than expensive than amyloid PET. So it's very good for the research purpose, but it's not enough to be being used as the clinical practice. It's too expensive, and there are many many kind of the point we have to optimize. So it's not easy to measuring the many kind of the blood markers by the Simoa. It's not easy. It needed a very highly qualified technique.
Yeah, thank you.
Okay. Professor Kim,
Yes.
do you ever check your data, compare your oligomer A beta with p-tau, plasma p-tau?
Yes. Only p-tau 181. It is well correlated.
Okay. Okay, that's question from Dr. Lin Yongquan. The first question is there any relationship between MDS or beta or oligomer A beta and the cerebral tau pathology?
Actually, we didn't do the comparison study between the MDS and the tau PET or the pathological study. We just did the comparison study between the MDS OA beta and the CSF p-tau t-tau. And the MDS is well correlated with the p-tau 181 of the CSF value only. So we have to more study. We're planning to study for the tau PET, but it's not done yet.
Okay, and the second question is, why most severe AD case had low MDS oligomer A beta?
Sometimes the MDS OA beta, when we clinically diagnose someone as the patients have very typical Alzheimer's disease, but the MDS OA beta is lower. In that case, we have to consider some other cases. The first of all is the late. The TDP-43 neuropathy is very similar with the Alzheimer's disease, and the severe, very severe cases of the Alzheimer's disease can have the lower value of MDS OA beta or the other history of chemotherapy, history of long-term steroid therapy, history of the passive immunization or BACE inhibitors, or like that. In this case, the person can have the very low value of MDS OA beta. But I think the very small portion of real Alzheimer's disease, but they can have the not high value of the MDS OA beta, but we don't know the percentage or the mechanism now. Anyway, there is no biological test is perfect.
Okay, one more question. Do you think this technique, MDS, can be applied to other AD blood-based biomarkers?
Sure. In Korea, it is commercially available. So until now, more than 100 clinical clinics, the dementia clinics, are using this technique as a basic test, for the diagnosis of Alzheimer's disease already in Korea and Philippines and some other European countries already. And it's quite cheap. It tests the 100 bucks, around the 100 bucks by blood test. So we can test repeatedly every year or every 6 months to see some change of this kind of value. For example, when I see the patients with a very mild cognitive impairment and the high value of MDS, in that case, I recommend some drugs out of label medication, but sometimes it can reduce this value dramatically in that patients. So it needs some more time to confirm the relationship or the effect of a treatment. I think the lowering this MDS OA beta value can prevent or delay the occurrence of the clinical symptom of Alzheimer's disease. It is fully available in Korea now.
Okay, in terms of plasma p-tau, do you think the p-tau 217 really better than 181?
Yes, I think according to the recent data, probably in the clinical practice setting, the p-tau 217 is more practical than the p-tau 181, but until now there is no commercial service for the p-tau 217. The specific antibody for the P217 has the Eli Lilly, which is not commercially available. So many centers are developing their own antibodies for P217, including our centers. But after we developed this kind of the new antibodies for detecting P217, but the sensitivity and the specificity is another problem. We have to test again. But the recent data of the P217 in the paper is using the Eli Lilly technique. So it's a very specific antibodies, but it's not commercially available now.
Okay. There's a question from Dr. Huang Likai. A-beta oligomerization tendency is happen in blood as well as brain in a similar manner. Is it right?
Yes, that's the one of a big point. Even until several years ago, many scientists think the beta amyloid originated from the neuron in the brain and is leaked out to the CSF and transmitted to the blood. But actually, beta amyloid is produced by many kind of organs, liver, pancreas, or the kidney, or platelet, or like that. So the problem is, what is the difference of the centrally originated beta amyloid and peripherally produced beta amyloid? I think those are exactly same. Exactly the same. So one is the central, one is from the centropetal and the centrifugal pathways. So our team thinks the peripherally produced beta amyloid can enter the brain and make the amyloid plaque very exactly same way.
How did A-beta oligomer penetrate the BBB?
No. Probably the very small form can enter the brain MRI and make the oligomers in the brain. Our technique, the MDS-OA beta, is measuring the plasma characteristics of how fast they make the oligomeric form of beta amyloid in plasma, not measuring the real oligomeric beta amyloid in plasma concentration. A totally different mechanism, different techniques.
Okay. Any other question? Okay, we almost run out of the time. And thank you very much for Professor Kim to provide us a wonderful talk.
Thank you for inviting me to this kind of very reliable lectures. And I will see you again in here. Yeah, we have to see.
Yeah.
Bye-bye.
Okay,
Bye-bye. Thank you.
Bye-bye. See you later.
Yeah, see you.
See you.